Sniad. My lady, please may I call Baroness Elined Morgan.
Tynga fi ddiw holl alluog y bydd y dystiolaeth a'r orddaf yn wir yr hollwyr a'r gwir yn unig.
Baroness Morgan, I know how busy you must be, and I promise you we will finish your evidence today so you can get back to your other duties.
Thank you.
Can you give your full name, please?
Elined Morgan.
Baroness Morgan, prior to becoming the First Minister of Wales, you were the Minister for Health and Social Services from May 2021 to March 2024, is that correct?
That's correct.
I think prior to that role, you served as the Minister for Mental Health, Wellbeing and the Welsh Language from October 2020 to May of 2021, is that right?
That's correct.
And I think when the pandemic began, you were the Minister for International Relations and the Welsh Language, a role that you held from December 2018 to October 2020, is that right?
That's correct.
If we can begin today, considering the period when you first came into the role of Minister for Health and Social Services in May 2021. So at this point, the second wave of COVID had ended and COVID-19 rates in the community were relatively low at that point. In relation to health rather than social services, that aspect of your portfolio, what were your priorities when you became Minister for Health and Social Services, and how did you identify those priorities?
Well, I was still very aware that we needed to continue with the vaccination programme, so that was important. I was very aware that we needed to switch the planned care programme back on to get back up to speed. There were issues in relation to social care. I was very concerned about long COVID and the need to make sure we had a good programme in relation to that. I was concerned about making sure that Test, Trace and Protect was still in place when we needed it. So those are some of the key things that I was focused on.
And did you identify those priorities because of what you knew already from working in government, or was it your officials within the Welsh Government civil service, effectively, who identified those priorities to you?
So I had a meeting when I first started with the Director General of Health, who ran through a whole series of challenges that were facing the NHS, and they were numerous. So it was a question then of where do you focus your priorities, where do you focus your attention? I mean, this is a huge brief, and it's very difficult to get a head around such a lot of things, so it made sense to try and focus.
If we can look at your powers and responsibilities as Minister for Health and Social Services, and you set out in your witness statement the various areas for which you had responsibility, but you explained that in terms of the healthcare system in Wales, operational decision-making was the responsibility of the local health boards and the NHS trusts, who had a broad discretion to formulate their own policies, and that your role as minister was limited to focusing on the strategic direction of the healthcare system, approving the health board plans and providing funding. And this inquiry has heard from the Director General at the time, Andrew Goodall, who explained that as minister you retained responsibility in a health emergency for preparedness, capacity and increasing capacity and resilience. We also heard that there isn't a central health emergency organisation that can take national command and control of the healthcare system in Wales. And so can you help us with this? Do you think, with your experiences having been the minister during the latter part of the pandemic, would there be benefit in a pandemic situation either for the Welsh Government to have some greater powers to direct the response of the healthcare system, or for some other national body to be able to take command and control of the NHS to coordinate the pandemic response?
I think some of that was done centrally. So the vaccination rollout, for example, was very much centrally driven. But by now, there is an NHS executive that exists that didn't exist at the time. So that centralised approach is something that's been developed since then.
I think it's right that the NH executive doesn't have statutory powers, so it doesn't have the powers to direct the healthcare system. Is that right? Or is it that the minister can use the NHS executive effectively to give ministerial directions?
So we can, there are methods of ensuring that the NHS health boards do what we want them to do, including through the framework and including obviously through financial means. So we have accountability mechanisms as well. So have regular meetings with the health board chairs, and certainly later on I was holding them to account in a very detailed way in terms of what was being delivered. So accountability is certainly something that I noticed needed to be tightened up, and since then there's been an accountability review.
Thank you. You've also explained in your witness statement that in the discharge of your ministerial responsibilities for the healthcare system, you relied heavily on the advice from the Chief Medical Officer, Chief Nursing Officer, and also the Director General of the Health and Social Services Group. Did you always feel that you had the information that you needed, or did you ever feel that you needed more specific expertise or detailed information on a particular topic?
I think in retrospect, I'd have liked to have other views, and that's one of the things that I developed since, was to get to set up a system where we have a ministerial advisory group made up of people who are outside the system, including people from who are outside from England, who are kind of kicking the tires on how we do things. And I think that's something perhaps it was very difficult. Sometimes if you're not in a pandemic, you can get to the front line and you can speak to people on the front line and get a sense of what's happening from the front line. It's more difficult in a pandemic because there were rules about who should be going into hospitals. So that kind of triangulation that you can do usually. But obviously we did have advice, and I spoke regularly to different organisations, BMA and lots of organisations were coming in regularly, just obviously all online.
Can we have a look at some of the information and data that was made available to you in terms of hospital capacity, first of all? And I think it's right that you received regular emails about hospital capacity, which included a table of the available and occupied beds. And if we can have a look at one of the example emails that you've provided to the inquiry. Thank you. This is from the 16th of June 2021. And we can see there, this is an update from Andrew. I think that will be Andrew Goodall, I assume. The Minister NHS update for the 16th of June. The NHS has had a busier week and started with some visible pressures on Monday, with at one point 7 level 4 sites yesterday felt particularly difficult and consistently across Wales, with high normal levels of activity and evidence of long handover delays and constraints on patient flow. And says this morning still reported 7 level 4 sites. Now the inquiry has heard about different levels in different mechanisms, CRITCON and so on and so forth. What do you know what level 4 sites meant in this context?
Yeah, I think it's probably worth noting I'd only been in a job a month when this was sent, so I was really trying to learn how the system worked, and I wasn't too familiar with how the levels were set, which is why I asked the question, and I didn't quite understand how they could say that some of them were at perhaps a lower level than I expected sometimes, because I knew that there was a lot of planned care pressure, but this was about urgent pressure. It was about day-to-day pressure, and that's what this particular approach, the escalation process, is about, the day-to-day and the pressure on the system on the day, rather than the kind of more planned care concerns that I was starting to be worried about.
So can you help us? What does level 4 mean in that context?
So level 4 means that that they're already using the additional bed capacity that needed to be used, but level 5 would be the one where actually everybody's in, everybody has their leave cancelled, everybody. So this was one down from that. But, you know, level 4 was pretty consistent in many places for a long time, and indeed even today, the pressures are huge, and we have pretty consistent level 4 levels still.
If we can go over the page on that email, please. I think we can see the table, and we've seen a similar table from earlier in both in March and in April of 2020, prepared by Andrew Goodall when he gave his evidence. But we can see that the numerical data that you're provided with at this point, and this is really between waves 2 and 3 in June of 2021. And so we can see that you're shown there that the number of available beds in critical care and the occupied beds in critical care, and how many of those occupied beds are occupied by COVID-19 patients. We can see there's only one COVID-19 patient in critical care at that time. And we can also see under total beds on the right-hand side, number of non-COVID-19 occupied beds. There are just over 8,000 occupied non-COVID-19 beds. This is outside of critical care, non-critical care, it would appear. In terms of what isn't shown on that, it doesn't appear from this that you're told what proportion of the non-critical care beds are occupied. We can see that critical care beds occupied 72%, but you're not told how much available capacity there is for non-critical care. Would that have been useful for you to know, apart from just knowing that you're at level, that the sites were at level 4? Would it have been useful to know quite how full the general acute capacity was in Welsh hospitals?
I remember certainly on a weekly basis monitoring this quite closely and just trying to work out how near to capacity we were. So although it might not have been on this particular graph, I remember being clear about how many critical care beds we had, and therefore you can work out pretty quickly how many were available to us.
And what about the non-critical care beds, the other activity? Just the general acute beds that would be on a normal acute ward. Would it have been helpful to know how many of those were unoccupied? I think you're only given on here, it appears, just the number of beds that were occupied.
Yeah, but I mean, I was very aware that we were very much near capacity.
This table also doesn't give any idea of whether those critical care beds are level 2 or level 3. We've heard about that differentiation. It's intensive care or high dependency care, and the staffing ratios that differentiate between those two levels of care. And indeed, there isn't any information on this about what staffing ratios are having to be employed, which is another measure of surge capacity and how stretched the critical care units might have been. Albeit that this is at a time between the COVID surges. By the time that the Omicron surge hit in Wales, would it have been useful to know about staffing ratios in critical care, or indeed the number of patients receiving CPAP, for example, outside of critical care? That's something that we saw that data had been collected earlier in the pandemic. It doesn't seem to be here. Were you ever given any information about COVID patients receiving CPAP and how close that was to capacity?
I can't remember getting that information on CPAP, but if you look at the number of COVID-19 patients in occupied beds, they were actually quite low.
At this point, yes. Yeah. But later in the pandemic, when the Omicron wave hit, and
Sure.
there were more patients hospitalised. Were the data categories, did they change at that point when there were more COVID patients? Were you given more detail about the kind of clinical support that was available for COVID patients?
I can't remember getting that information at that time, no. But I was aware that there was a lot of pressure in terms of staffing in critical care, and I was aware, particularly later, that there were difficulties in recruiting to emergency departments in particular, and critical care as well.
I think also on here, we can't see whether there are any beds available in field hospitals. Were you given information about any available beds in field hospitals? Was that something that you were given regular updates on?
No, because I think the kind of I think they were included in the health board's numbers. So there was a surge capacity effectively, which was counted in these numbers.
Thank you. Aside from this sort of numerical data, then, you mentioned before about how difficult it was to go into hospitals and find out what was happening on the ground. How did you hear from frontline healthcare workers about the pressures on the ground, aside from the numbers?
So as soon as I was able to enter hospitals, I used to do a lot of unannounced visits. I used to just turn up at hospitals and get a sense from patients waiting, how long they've been waiting. I'd manage in particular to go into emergency departments and to listen to what people on the front line were saying. And they were always really pleased, because quite often if you turn up as a minister, they've cleared everything up before you arrive. But what I got was a much more authentic view on pressures and what was going on. And I think it was really appreciated, because it meant that I could speak to them. If you go in and you're surrounded by 15 managers, you don't get to the people who are actually coping with it day in, day out. And I found that really useful. I did it around Wales quite a lot as soon as I was able to get into hospitals when the levels of the infections had reduced. And
did the picture that emerged from speaking to those people when you went to visit hospitals, was that a picture that was in contrast to the information you were getting from the purely numerical data, or did those two things marry up?
They definitely married up, but what you don't get from numbers is a sense of how people are feeling on the front line, of the pressure they're under, of the intensity of the work that they're undertaking. I remember, I even went out spent the day as an ambulance worker with the ambulance drivers, and there were people who were breaking down, and it really brings it home to you when you realise the pressure they're under. No graph is going to tell you that.
The inquiry has heard repeatedly that there was a focus in all 4 nations of the UK on ensuring that the NHS was not overwhelmed. What did you understand overwhelmed to mean? What would your measure of the NHS being overwhelmed have been?
I guess there's different ways of describing what overwhelmed means. Did we have enough beds? I don't think we ever ran out of beds, but were the people working in the NHS overwhelmed? Yeah, I think there were a lot of people who were working in the NHS who were definitely overwhelmed, and I'll never forget speaking to some of the people on the front line about how they were feeling. They were breaking down, and there was a group who came to present at the Senedd, the Royal College of Emergency Medicine. They came to the Senedd, and it was really harrowing to hear what they'd been going through and how clearly traumatised they were.
Can we move on to a new topic, please, and that's nosocomial infections and IPC measures, infection prevention and control measures in Welsh hospitals. In your witness statement, the first briefing on nosocomial infection rates that you identify is from the 30th of June 2021. Do you know whether that was the first time that particular issue had been brought to your attention as Health Minister?
Yes, I'd been in post about a month and a half by that point.
And if we can have a look, please, at the briefing that you were provided with at that time, and we can see that Public Health Wales data for the 1st of March 2020 to the 30th of May 2021 indicates 7,127 probable and definite nosocomial COVID-19 infections in Welsh hospitals. And on page 2, we can see that Health Board self-reported data to the Welsh Government outbreak reporting system indicated that from the 23rd of November to the 23rd of June 2021, during the second wave, there were 232 outbreaks in Welsh hospitals, in which 3,387 patients and 1,360 members of staff tested positive for COVID. And then we see below that there's a note that all nosocomial COVID-19 infections are incidents of patient safety, and therefore health bodies are obliged to investigate these under putting things right. I think that was a pre-existing process that existed for patient safety investigations in Wales. And then below that, we can see that there's reference to the national framework on managing patient safety incidents following nosocomial transmission that requires health bodies to contact patients or their families where harm has been caused. And then there's a note that potential claim values vary widely. Initial estimates range from 7.7 million to 69 million pounds. Do you think that this focused on the cost of potential civil claims arising from individual cases, rather than adopting a no-blame culture, may have deterred local health boards from candour and openness when they were trying to tackle this ongoing problem of nosocomial transmission in Welsh hospitals?
Well, I certainly wasn't aware of a focus on money. I think the focus was far more on how do we make sure this doesn't happen again, and trying to learn lessons from the fact that we had high levels of transmission within hospitals. So I'm surprised that I'd like to think that that they weren't focused on money, but they were focused on sorting things out so it wouldn't happen again.
I think it's right, isn't it, that the National Nosocomial COVID-19 programme, which was about the way that this national framework had been implemented, and it provided an interim report in August of 2023 and a final report in 2024. That framework was developed to ensure that local health boards were investigating individual patient deaths from hospital-acquired COVID as a patient safety incident. Why was there no national investigation into the causes of cluster outbreaks in hospitals or the persistent problem of nosocomial transmission in Welsh hospitals?
Well, every single individual case was investigated, 18,630 odd. So I think ours was probably more detailed in terms of why things were happening and trying to make sure that we provided, that we learnt the lessons, and there was a huge amount of work done by the Wales National Framework in terms of making sure that they took account of all of the things that they needed to assess, things like PPE and ventilation and bed spacing and visiting rules. So all of that was in the National Framework. So I think the investigations could not have been more thorough in terms of the numbers of people, every individual being investigated.
But there were investigations into individual cases, weren't they, rather than investigations into the causes of cluster outbreaks within a particular hospital or health board?
Yeah, but it's actually really difficult to get to what exactly is the cause, because there are potentially lots of causes, and what what that group did was to look at all of the potential causes. So to be able to say definitively this is the precise cause, I think would have been quite difficult.
You've set out in your witness statement that in May of 2022, you were sent and reviewed 2 public health reports, one of which was called Lessons Learned from Nosocomial Outbreaks, September 2020 to April 2021. I don't think we need to get that up, but it shows that nosocomial infection rates in Welsh hospitals were worse in wave 2 than in wave 1. And the conclusion on page 8 of that report was that not all lessons identified at the end of wave 1 were actioned successfully. Were you concerned on reading that this meant that nosocomial transmission in Welsh hospitals may have led to a significant number of preventable deaths in wave 2?
Well, I think it's important to note that some lessons were learned. The spread of asymptomatic COVID, for example. So there were lots of lessons that were learned, but the fact that we had a follow-up report to find out why they hadn't implemented the recommendations of the first wave, I think is something that, probably needs to be explained by the health boards.
What steps did you take as Health Minister to try to address the problem of nosocomial transmission in Welsh hospitals?
Well, we were very strict in terms of visiting, so we had to make sure that those kind of measures were put in place. There was a lot of support in relation to ventilation by the NHS Wales Specialist Estate Service, because I knew that there were lots of people who thought that we had a very old estate, and that is very difficult. So lots of our wards are open wards, they're not individual wards, and obviously it's much more difficult then to stop the spread. Making proper use of PPE, making sure that there was good bed distancing, all of those things were things which were brought up in that Wales National Framework. So there were opportunities for people. People knew what they should be doing, but actually if you've got quite an old estate, it is much more difficult to control the spread than if you are able to isolate people in individual wards.
Given that shielding people and those more clinically vulnerable to COVID-19 were going to be at higher risk from contracting COVID infection and also likely to be frequent users of healthcare, were there any efforts made to identify or monitor the number of clinically vulnerable and shielding people who had contracted COVID-19 within healthcare settings? Do you know?
Well, all of that would have been monitored, I assume, on the wards themselves by the people who are responsible for the operational duties within particular wards. So that should have been on their notes.
You've set out in your witness statement that when the Omicron variant arrived in Wales, you were particularly concerned about the impact that this more transmissible variant could have on nosocomial transmission rates. Did you consider at that point that it may be necessary to have a review of IPC measures to ensure that the right protections were in place in hospital settings?
It was something that I discussed with the Chief Medical Officer. We did tighten up some of the rules just before Omicron hit, so we actually actioned some things prior, as soon as we knew that Omicron was present in the country. So measures were taken at that point. You
mentioned there that one of the measures you focused on in particular was visiting in relation to trying to address nosocomial transmission rates. So if we can look a little at some of the changes that you made to the hospital visiting restrictions when you were minister. You've set out within your statement that you saw it as quite important to allow local healthcare providers to depart from national guidance on visiting in response to local transmission rates, although that would necessarily create some inconsistencies in approach across Wales. Can I ask you this? Did you consider any specific communication strategies or other measures to try to help explain to affected families why these variations were occurring, and particularly at points when wider societal restrictions were lifting but visiting restrictions were remaining in place?
There's a huge amount going on at this time, and obviously the key thing was to communicate with the people who had to implement the rules. So getting the guidance out to the people responsible for implementing was the most important thing. And then secondly, obviously, to make sure that those who needed to visit understood why. But the fact that there was a kind of national guidance, but there was a degree of flexibility locally, meant that there was an opportunity for house boards to respond to local circumstances. So, COVID went through in waves around the country, and whilst it would have made sense in some areas to tighten things up, and this happened on a number of occasions, where house boards just saw a wave coming at them, and they tightened everything up. They stopped. They restricted visiting for a short period, and then they loosened up again. And we thought that approach made sense, which gave the flexibility. But obviously there were times when we needed to be sensitive to some specific cases.
Were you provided with, or did you request any advice or supporting information from IPC experts about the contribution to nosocomial transmission rates from visitors coming into hospital? To what extent was it the case that visiting restrictions impacted the number of nosocomial transmissions that seem to be taking place in Welsh hospitals?
I think we're really aware, because of what we'd seen, particularly in healthcare, care settings, that sometimes some care workers moving from place to place actually was part of an increased risk. So if that was true for professional workers, then the same would obviously be true for people who are not professional workers. So we were already sensitive to it and learning the lessons from the first wave, where we saw that happen in some instances.
Can I ask you specifically about visiting guidance for maternity services and for pregnant women? I think you were responsible for amendments to the visiting guidance on the 9th of May 2022. This was the first time that the guidance specified that a birthing partner was not to be counted as a visitor. And this was over a year after England had made this distinction between birthing partners or birthing support, and visitors in their guidance. And I'd like to ask whether you consider that the guidance for Wales should have always specified from the first guidance that birthing partners were partners in care and not to be counted as visitors.
If I had my time again, I would definitely have introduced that earlier.
I think thank you. Do you consider now, looking back with the benefit of hindsight, that the visiting restrictions generally in Welsh hospitals, not just in relation to maternity, but that they struck the right balance between the benefits to patients of having visitors and supporters and reducing the infection risks of visiting? Do you feel that the balance was struck in the right place?
Not when it came to maternity. I think we also discussed, I remember as a cabinet, people who are perhaps receiving a diagnosis where it was possible that they'd have cancer, that probably we should have been more flexible in that kind of instance as well. So I think there are a few instances where we might have done things slightly differently. But the fact that there was a clear national guidance, but the flexibility locally to respond, I think that was probably the right thing at the time.
If we can move on to a new topic, please. You mentioned that one of your priorities on coming into office was the recovery of elective services and planned care. When you came into post in May 2021, what did you understand to be the primary reasons for the backlog of patients awaiting diagnosis and treatment for conditions other than COVID-19? And what were the main obstacles to recovery of elective care at that time?
Well, we've been very clear that the focus should have been on urgent cases, on cancer, and there was huge, and on emergency services, obviously. And in Wales, you have a situation where we don't have many major cities, so it was really difficult to have planned care separate from emergency care. And so emergency care knocked out planned care quite regularly, and that clearly caused a problem. But I think, there was lots going on in health at the time. It wasn't just about planned care. In Wales, we have 2 million contacts a month in a population of 3 million people in the health service. It's the demand on the service is enormous. And so you've got to remember the context of having to keep all of that going at the same time as well.
For winter 2021 to 2022, the winter plan that you announced for that period was clear that due to that projected increased pressure on the NHS, the number of patients receiving planned care would reduce. You said this: on planned care, we will be straight with the public and explain that it will be tough to work through the high numbers on our waiting list over the winter, and we may need to flex the system and reduce the numbers receiving planned care treatment if the pressure on the system continues to mount. Was there any consideration given to using field hospitals or independent sector facilities as elective hubs to enable elective care to continue through that winter?
Well, when it came to field hospitals, the issue with field hospitals wasn't the beds, it was having the staff to be able to operate the beds. So the problem doesn't go away just because you can provide field hospitals, you still have to provide the staff. And so that was the problem there. When it came to the private sector, I think there's got to be an understanding of the number of beds in the private sector in Wales. We have 172 beds in the entire private sector in Wales. So whilst in England, I think they cleared about 18% of their waiting lists through private sector, we had 172 beds. So we did use the private sector, but obviously it's not much to use there. And we did actually use some private capacity in England as well. So it's not as if we didn't do it. It's just that actually the provision is a long way from Wales, and that definitely made a difference.
Can I ask you about the issue of health inequalities in terms of elective care? You refer in your witness statement to an evidence paper prepared for the Health and Social Care Committee investigation into the impact of the waiting times backlog on people in Wales. That paper, I think, was prepared in February of 2022. And it noted that investment to increase capacity had not been provided until 2021, and also that deprived areas face disproportionately large waiting lists per head of population compared with the least deprived areas. And can I ask whether you took any steps as Health Minister to address that health inequality in relation to elective care specifically?
Well, I mean, that wasn't anything new. The demands, we have an older, sicker, poorer population, and it is concentrated in various parts of the country. So we went into the pandemic with people in those areas facing longer waiting lists anyway. I think the other thing to note is, for example, it's quite difficult to recruit sometimes into some of those areas, particularly into rural areas. So, people, a lot of medics want to be in cities, and that makes it much more difficult. And I think the other thing that's worth noting is the challenges of delayed transfers of care, and that was becoming an increasing problem. Particularly if you can't separate out planned care from emergency care, like you can in big cities, where you have two hospitals in a similar area, that is really challenging. So we are developing surgical hubs now, but they have to be developed very much on a regional basis rather than it within health boards, because there's just we just don't have the population base to hold those. So those have been developed since, are being developed, but it's a new approach because you need it to happen on a regional basis, and that's something fairly new in our system.
The inquiry's heard from two experts in orthopaedic surgery, Professor Metcalfe and Ms Chloe Scott, and I think a transcript of their evidence has been provided to you. They explained to the inquiry that the delivery of restoration of elective care in Wales was significantly delayed compared to what was happening in England. And Professor Metcalfe told the inquiry that the first guidance document on recovery of elective care orthopaedic care was released in 2022, and the Welsh guidance document was much more vague than the NHS England equivalent, and importantly was not linked to any financial incentives, and consequently treatment delays in Wales were, in the words of Professor Metcalfe, absolutely huge. Do you think that the Welsh Government should have planned to recover elective care sooner in the pandemic and taken steps to incentivise the local health boards who were able to restore elective services?
I do think it would have been better to have perhaps come up with the plan sooner. I'm not sure if it could have been implemented sooner with the pressures that the system was under. So our system is not one currently that is driven by financial incentives. There's an understanding in some quarters that perhaps sometimes leads to unintended consequences. But I think also that there was a need for not just us to be more deliberate in terms of ensuring that we knew exactly what was going on within these orthopaedic hubs, but more than that, the health boards needed to know what was going on. So again, I did one of my unplanned visits to an orthopaedic hub on a Thursday afternoon, and I found that there were 13 surgeons not working. They weren't there. So, the monitoring, the management was not happening in the way that it should have been happening.
That brings me on to my next question, which was whether the Welsh Government monitored elective or planned care during the pandemic? Was it counted separately, if I can put it in that way? Was there a monitoring of how much activity was going on?
Well, I initiated very, very careful monthly monitoring where I asked for details on what was going on, how long the waiting lists were coming, how quickly the waiting lists were coming down, particularly for those longest waiters. So, you know, I personally got really involved in monitoring what was happening on a monthly basis in terms of the planned care programme, because it wasn't going in the way that that I'd hoped.
Do you think that future pandemic plans should include a specific strategy for the continuation or at least the prompt recovery of elective care?
I think having a plan is easier than actually making it happen, particularly if you can't separate out planned care from emergency care. And that was one of the real difficulties for us. You know, we didn't have the private hospitals to the extent they did elsewhere. We didn't have the orthopaedic hubs, although, you know, the orthopaedic surgeons gave really clear direction in terms of what they wanted to happen. But again, you know, I visited one of the few orthopaedic hubs that we had, and they weren't working. So, you know, I do think people have to be held to account within a system.
Did you discover why they weren't working? Forgive me, I'm losing my voice.
I was given an explanation.
Sounds as if you didn't accept it.
It wasn't what I expected to see, and I took steps afterwards to make it clear that things had to change.
So it wasn't that they were off sick or anything?
They were not.
Whatever the explanation was, it was not a satisfactory one?
It was not a satisfactory one. I'm happy to send perhaps the letter that I wrote to you. Might be of interest.
If we can move on then to some questions, please, about shielding. I think it's right that the shielding programme in Wales was paused in March of 2021, so it was paused when you came into post as Minister for Health and Social Services. And in fact, it wasn't reinstated during your tenure as a Minister. I think that's right. But I think there were certainly at least two occasions when you received advice from the Chief Medical Officer for Wales as to the position of people on the shielded patients list, and you were given given some advice or some options about either reinstating the shielded patients list or indeed closing the shielded patients list. I think in July of 2021, in the light of the planned relaxations for the general community, in terms of COVID restrictions being relaxed, the Chief Medical Officer advised you that the shielding programme should not be reinstated, but he intended to write to the clinically extremely vulnerable, advising them to take extra care to minimise their exposure to the infection, to meet outside where possible, keep contacts to a minimum, and to continue social distancing. Why did you not consider it advisable to reinstate shielding at that point if the lifting of restrictions in the general community may place those people at greater risk?
Well, because by this point they'd been vaccinated, so they had a degree of protection, and this was really just a precaution for them to give them more confidence to know, look, actually, we know that things are going to open up, that there is a potential for it to spread. This was happening in the summer, so it was less likely to spread than in the winter. But we just wanted to give them confidence and to give them reassurance, right, these are the measures that you can take if you do want to protect yourself, because it wasn't a one-way thing. There were some people who were really concerned because of their vulnerability, and they needed to be given that additional guidance in terms of what might help them to avoid contracting the virus despite being vaccinated.
Were the steps set out in the Chief Medical Officer that I've outlined not effectively advising those who had been on the shielding list to continue to shield, but simply without any government support to do so?
No, we weren't advising them to continue to shield. We were giving them tips on, the Chief Medical Officer was giving them tips on how to avoid obvious things, like don't go to a disco. You know? It's just kind of common sense approach, I think, just reminding them of how mixing with people, in particular in close set environments, would likely to increase their risk of contracting the virus.
I think it's right that in December of 2021, Rebecca Evans, member of Senedd, wrote to you with a request to reinstate the shielding programme in the light of the concerns about the emergence of the Omicron variant. And in that letter, she stated that vaccination is only effective in 40% of the clinically extremely vulnerable. I think on that occasion, the Chief Medical Officer of Wales again wrote to those on the shielded patient list, reiterating the advice to take extra precautions, but the shielding programme was not reinstated at that point. Did you consider whether this might be, with the emergence of the Omicron variant, in the middle of winter 2020-2021, that this might be a time when it would be appropriate to reinstate the shielding programme?
I got advice from the Chief Medical Officer. I think it's probably worth noting at the time we weren't sure how Omicron would affect people. I think there was a degree of confidence that the vaccine would be able to withstand Omicron, but the letter was once again to give them reassurance, and by now, of course, we had the retrovirals as well that could also be given if they did contract the virus.
In the light of the concerns that those who are severely immunosuppressed may not be able to take the vaccine, or the vaccine may be less effective in those people, was there any consideration given to extending the shielding programme with all the protections that had, for example, access to statutory sick pay and so on, for that cohort within the shielded patient list, so those who were severely suppressed?
It was considered by the Chief Medical Officer. Of course, by now it had already been dismantled in England. So we thought that it made sense for us to again give them advice on how they should protect themselves.
You've referred in your witness statement to having to balance the benefits of shielding against the disbenefits, such as social isolation and so on, when you were deciding whether to reinstate the programme. Beyond the concerns of individual constituents being brought to your attention by members of the Senedd, did you seek to ascertain the views, or ask your officials to ascertain the views of the clinically extremely vulnerable in terms of the impact on them of being asked to shield, or indeed of pausing the shielding programme?
Well, before becoming Health Minister, I was the Minister for Mental Health, and we knew that there were a lot of people who had been suffering, particularly younger people, as a result of the need for them to self-isolate. So it was a question of balancing. In terms of the clinical extremely vulnerable, then that was the CMO would have been looking into that.
Can we come on, please, to look at long COVID? You've explained in your witness statement that by the time you were appointed Minister for Health and Social Services, there were established systems and processes already in place across the NHS in Wales for the management of long COVID. And you've explained that you received advice in June of 2021 that funding of £5 million was required to support the expansion and development of primary and community services for those recovering from the effects of COVID-19. Do you think that the funding should have been made available earlier than June of 2021?
Look, I could only speak for myself. I was appointed in May. It was an area where I felt we probably needed to do a little bit more work, and within a month we had a new programme. We had £5 million in that programme. I think I was really sensitive to it because my brother-in-law had been suffering with it, so I was probably more attuned to it, and thought that we needed to do a bit more work in that space.
In terms of the model of clinical support for people with COVID, long COVID in Wales, I think you've been provided with the Public Health Wales International Horizons scanning report that was published in May of 2021, which advised that the multidisciplinary approach to assessment and management and patient involvement are all instrumental in addressing long COVID. Would you agree that the existing system that was in place when you became Minister in May 2021 was not providing a multidisciplinary approach to assessment and management of long COVID?
I think we were still trying to work out what long COVID was. One of the first things I did was to visit a multidisciplinary it wasn't a clinic, it was being carried out in a sports centre where several different therapists were brought together, and in fact I visited two of those as the project continued. So that multidisciplinary process, I don't know what was there before, but it was certainly being developed very quickly after my appointment.
I think that the programme that was developed, the Adferiad programme that was developed, was reviewed every 6 months, and the local health boards were required to submit reports on that. Is that correct? I think the first report was in January 2022, which you've summarised in your report. Is it right that that report also showed that some local health boards did not start offering services until December of 2021? And did you have any concerns that there seemed to be inconsistency across the local health boards in Wales as to the services that were being provided for people with long COVID?
But first of all, in terms of adferiad means recovery in Welsh. Long COVID, we were all learning about long COVID, and I was clear, if we're going to start a new programme on a condition that people don't know much about, we should make sure that we're reviewing it all the time, because the science was changing, the evidence was changing, we needed to keep up. So that was absolutely central to the programme, is that we had to just keep on updating it and finding out, was it addressing the issues, was it being effective, and was it keeping up with the science? And at the same time, we'd put about 700,000 into research on long COVID as well. But just in terms of the money and when it was being influenced, this came in June. The money didn't hit the ground until July. And so it's not something you can switch on overnight if you've got multidisciplinary teams that you need to pull together. So I'm sure that some were further ahead prior to the programme.
The inquiry has heard from two specialists in long COVID, Professors Brightling and Evans. And again, I think their transcript of their evidence has been provided to you. Professors Breitling and Evans told the inquiry that the gold standard for long COVID care is a multi-disciplinary team clinic, which is a one-stop shop for patients, and that hadn't been adopted in Wales. And furthermore, that the variation between local health boards in the services for long COVID was a disservice to patients in Wales. Was any consideration given to adopting long COVID clinics as evidence emerged of their clinical and cost effectiveness?
Well, the way our NHS is organised is very much community-based. It is a model that is in keeping with our strategic plan, A Healthier Wales. Very interesting to see that Lord Darcy is now recommending that's what should happen in England. And so we needed to provide a model that worked within the structures that we have within Wales. And those structures are always to try and give support as close as you can to where people live. So there was a mechanism via your GP. We made sure everybody knew what the pathway should be via the GP into the multidisciplinary teams, and then on, if necessary, to specialist support services. And what we found when we assessed the programme was that there was a very high degree of satisfaction from the people who used the services. I think 87% of people said that they would recommend it, and that only about 3.5% of people were referred on to those to secondary care, effectively, who needed that real specialist support.
I think the January 2022 report referred to those results from the CEDAR evaluation study that you've referred to. Were you aware that that CEDAR evaluation study, that was a survey of patients, also included some negative feedback? Nearly 30% of existing service users rated the long COVID services in Wales as average or below, and that some existing users felt that treatment was too generic and the service was not helpful overall.
Well, you obviously can work out if you've got, 83% who would recommend it to their friends, or 70% of people who are satisfied, that there's 30% who are not satisfied. So, there's still people suffering with long COVID today, and they haven't had the answers that and the results that they'd hoped. So, I can see why they would feel frustrated. I'd be surprised if you get to 100% satisfaction with specialised COVID clinics.
If we can move on, please, to look at primary care and the changes made in primary care during the pandemic. There was a perception that people could not get an appointment to see their GP, and that face-to-face appointments had been stopped entirely. What do you think caused that perception, and could more have been done to dispel that perception?
I think at the beginning, people thought everything had shut down, and there was an opportunity. I was married to a GP. I am married to a GP who was on the front line every single day, so I was very aware that he was going into work, as were all of his colleagues. That perhaps wasn't something that was recognised by the rest of the public, but we made it very clear that, GP surgeries were opened, albeit not in the usual way. So, for a long time, they weren't doing face-to-face, but they were doing online consultations. They were doing telephone consultations. And one of the things we did in Wales is to make sure we continued with that understanding that actually you're not going to get a face-to-face appointment with a GP every time you ask for one, because actually the system worked quite well for other people. And since then, we've changed the GP contract in Wales so that we've got rid of lots of the issues that exist elsewhere and existed before, because we've changed that contract.
Did you take any steps as Health Minister to ensure that GP surgeries in Wales were making face-to-face appointments available for those patients who needed them?
So it was up to the clinicians, to the GPs themselves, to determine and to do the triaging in terms of who needed to come in. I don't think it would be appropriate for a politician to say, you know, these are the people who need to come in, these are the people who need to be seen. You know, that is the job of a clinician, and they had to do that risk assessment themselves.
Do you think the Welsh Government made it clear enough to GPs that they had to continue to offer those face-to-face services for some patients? I
think we did make it clear. We're very aware in Welsh Government of the equalities issues and the difficulties, perhaps in particular of older people who perhaps find it difficult to have some of those conversations on the telephone or not face-to-face. So that should always have been a service that was available. I'm not sure if I'm aware of any who didn't provide that, but they are the ones who had to determine who should come in and who shouldn't.
I'd like to move on, please, if we move to a new topic, DNA CPR notices and concerns about blanket or inappropriate application of those notices. I think it's right that on the 1st of February 2022, you were informed by Mike Hedges, member of Senedd. This is at paragraph 292 of your witness statement. Mr. Hedges was informing you of the concerns of the COVID bereaved group, that DNA CPR notices had been issued for their loved ones without any discussion with the relatives. And you made a written response, I think, to Mr. Hedges, which referred to the All Wales DNA CPR policy, and the fact that that policy explained there should be always consultation with those concerned when a DNA CPR notice was being considered. Given that the report of Mr. Hedges was clearly that All Wales DNA CPR policy had not been complied with, did you obtain any further details from him to investigate where and how those specific incidents that he was complaining about had occurred?
Oh, I can't remember if I can't remember. I'm sure that we would have followed that up, but I'd like to have the opportunity just to make sure that is what happened, because I know I was really concerned about it, and concerned about any instance where there was a suggestion that happened, because we had a very clear policy on this. So clearly, if that was happening, they were not following the guidance that we'd put in place. And we had a report by Health Inspector at Wales who'd done a sample review, and they didn't raise any issues at the time. And I know they were very keen to make sure there was personalised and compassionate communication.
Can you help us, please, with when that Health Inspector at Wales sample review took place? The inquiry has heard that there was a review that was announced, I think, in October of 2023. Was this a review that took place during the pandemic?
I think there was one that took... If you wouldn't mind, I'd like to check that rather than give you something that was misleading.
You've also referred in your witness statement to another written question from a member of Senedd, Russell George, a couple of months later in April of 2022. Again, concerns about DNA CPR. And can we have a look, please, at your written response? It's INQ 480092. and you respond in this way. I'm aware that there have been some high-profile media reports of blanket DNA CPRs being applied, and have been notified of some isolated incidents where it's alleged that DNA CPR policy has not been followed. And you go on in your witness statement to explain that you're referring to the incidents that triggered the letter from the CMO and the CNO of Wales. You said that the Welsh Government takes these allegations very seriously and in each case has acted promptly to investigate and seek confirmation of the governance and assurance processes in place within the relevant health board to ensure these decisions are taken in line with extant clinical guidance. Wasn't the issue here not that there wasn't any appropriate policy or guidance in place, but that those policies were not being followed by individual clinicians? Rather than seeking assurance of their governance and assurance processes, why didn't the Welsh Government or you as Minister ensure that there was a review of DNA CPR decisions that had been made?
Well, I think that letter demonstrates that we were chasing down every case that we heard about. And clearly we expect people to follow our governance and our guidance. One of the things we did was to introduce a Wales competency framework, because part of the issue was just to make sure people knew what they should be doing. So we made sure that clinicians followed a competency framework so that they knew how to fill up DNA CPR forms and to make sure that they did everything appropriately, including in particular making sure that they had compassionate communication, not just with the person involved, but also their families. And then the other thing that we did was to introduce a mortality review framework. So, and within that, there was a thematic review in relation to DNA CPR, and there was an action plan that had to be followed afterwards. So these were kind of actions, right, here's the guidance that looks like you're not all following. This is what we expect you to do as a result. So there was a follow-up.
And who was the competency framework made available to?
That was to the NHS clinicians, and there was a whole training programme that happened with that.
The inquiry has heard from the president or former president of the Resuscitation Council UK, who have developed the RESPECT form, which is a process used in parts of England and Scotland to note advanced care plans, including DNA CPR wishes of patients. And Professor Wiley told the inquiry that he considered it would be beneficial if there was one standard advanced care planning form, which would include wishes around CPR. If there was one form in use across the UK, particularly given the amount of movement that exists between the countries of the UK. Would you agree with that? Or do you think there are compelling reasons why Welsh patients should have a different process for recording their views?
I think there could be, there would be huge advantages to us having a common digital framework across the whole of the United Kingdom. We're all in different places on different things, though, so it's not straightforward to make that happen. But in an ideal world, I probably would suggest we need to try and collect data in a common way. And, you know, if you can fill in forms in a common way, then that would make sense as well, as long as we all agree with the policy. So, you know, as I suggested, that we had our own clinical policy. So, you know, you'd have to make sure that the policies were in keeping before you started to do that.
Thank you very much. That's the end of that topic. I wonder if that's a
Perfect
suitable
timing.
point.
3:25.
All right.
Baroness Morgan, can we look please at the actions that you took to address problems in the ambulance sector during your time as Minister? I think it's right to say that there were persistent issues with excessive ambulance response times throughout 2021 and 2022, and those problems were exacerbated by staff shortages due to high absence rates and lengthy handover delays at hospital. Is that correct?
That's correct.
I think in June of 2021, so after you'd been in post for about a month, having been provided with an interim report of the Ministerial Ambulance Availability Task Force, you requested a meeting with the Emergency Ambulance Services Committee. And you noted in that meeting that the national target for immediately life-threatening calls, red calls, had not been achieved since July of 2020. And that a move was needed, these are your words, a move was needed from review and diagnosis to radical and rapid focus on delivery of actions that are known to make a difference to patients. And in that meeting, you set out a number of expectations for the Health Board executives, for the Welsh Ambulance Services Trust, and for the Chief Ambulance Services Commissioner to develop a plan to address these issues. Would it be right to say that it appeared to you at this point that the ambulance committee members had been ineffective and slow to address the evident problems in ambulance response times?
I'm not sure if it's fair to say that. I'd only been in the post for a month. But what I can say is that I thought the time for talking was over and it was time for action. And so that's why when they asked me if they could have a 12-month extension on the group, I said, no, give me a delivery plan and close this group down and get on with the job. So I was just responding to what I saw in front of me. I don't know what happened before.
How refreshing.
You go on to set out in your witness statement that, unfortunately, ambulance performance continued to decline into October of 2021, and you received, I think, a ministerial advice on the 19th of November 2021 requesting that you agree £5 million of additional funding excuse me, to the ambulance sector, which you agreed, I think, on the 22nd of November 2021, and that funding was for the recruitment of more frontline staff, clinical support desk staff, additional non-emergency transfer vehicles, and support for a make-ready depot for the ambulance crews to use. Is that correct?
That is correct.
I think in addition to that £5 million that you had agreed for the Welsh Ambulance Services Trust in November of 2021, during the autumn and winter of 2021 into 2022, you were also asked to approve a series of requests for military aid to the civil authorities, MACA requests, for additional drivers to assist the Welsh Ambulance Services Trust. And I think the first of those requests came in September of 2021. Can we have a look, please, at the ministerial advice supporting that request? It's for INQ 4860061. And we can see here at point 4 that data indicates that the Welsh Ambulance Services Trust should increase its emergency ambulance capacity to 150% in order to meet predicted demand, which doesn't include predicted demand from seasonal flu. and the Welsh Government have committed to continue with elective surgery over the winter period to meet the backlog from COVID-19. And I think over the page on page 2, 251 drivers were requested at that point to drive Welsh Ambulance Service ambulances from the 15th of October to the 31st of March 2022. That was an equivalent of an additional 42 emergency ambulance crews across the week. And if we can go to page 3, please, in support of that request at point 15, it's noted that it's necessary to take this action to reduce patient harm and suffering as a direct consequence of delayed attendance to in-community cases and calls for emergency ambulance response, creating a significant risk to life. And the penultimate bullet point there, the Welsh Government and wider public services lack the necessary capability and capacity to fill the tasks. Other options such as commercial alternatives have been explored. And finally, if action is not taken quickly, there is a significant risk to life. So the necessity of considering this additional support was made very clear to you, and the consequences of the situation continuing as it was were made very clear there. I think it's right that having received that advice on the 24th of September 2024, the Director General, Andrew Goodall, advised that rather than the 251 drivers that had been requested by WAST, just 100 drivers should be provided. If we can go, please, to his email to you setting out that advice. He says this in the middle of that paragraph: "Personally, I feel that an offer of around 100 military personnel is more likely, more practical to be delivered, would be higher than we had before, and would be equivalent in numbers to similar proposals in Scotland and Northern Ireland. Costs, obviously, would be lower accordingly." And I think that you accepted that advice from Andrew Goodall, and 110 drivers were provided for a period of 6 weeks. Why did you accept this advice from the Director General to offer fewer than half of the requested number of drivers, in the light of the very clear advice from the Welsh Ambulance Services Trust that additional capacity was required to save lives in Wales?
Well, that was just the first tranche, and later on we brought on about 250. So by the end of the winter period, they were far more than the 110 that were first asked for.
I think it's right that an additional request was made, I think on the 17th of November 2021, a further request for 251 drivers to support the Welsh Ambulance Services Trust. And you agreed that request, and you were informed, I think, on the 15th of December that the authorisation had been granted for the 251 drivers until the end of March of 2022. If the original September request for 251 drivers had been granted in full, would that not have avoided the need for the second MACA request that was made in November?
Well, what I know is that there was a 10% reduction from the first, in terms of impact on the first 100 that we got in. But obviously, I think the difference is we were building up into a more intensive period. So whilst in October you may need a certain number, by the time you get to February you need more. So that kind of stepping up makes sense to me.
Did lack of ambulance capacity continue to be an issue throughout the third wave of the pandemic, or did this seem to have solved the problem?
So, well, it's really difficult because, well, first of all, there was a capacity issue. And so this was going alongside the fact that I gave them 5 million extra to go and recruit more ambulance drivers. We were getting 100 new ambulance workers in, but you can't switch them on. You need to train them up. So the reason why we needed these in was to prepare those new permanent ambulance workers. So that was really helpful. Part of the issue here is it's not just all about the ambulance service. It's about things like delayed transfers of care and, you know, them sitting outside hospitals for a long time because you can't get people through the back door. So at the same time as this was happening, I was doing a huge amount of work on how do you get the flow through the system. You know, we created an extra 770 community beds that winter in order to help the flow. So you can't look at this in isolation to the other things that were going on. And also, don't forget, you know, there was an issue of the number of people who were absent in terms of work from the ambulance service as well.
I think you note in your witness statement that staff sickness was a persistent problem in the ambulance sector, and that the ambulance workforce had markedly higher absence rates than other sectors of the healthcare workforce. Were you able to ascertain the reasons why that sector was particularly badly affected?
I met with the ambulance service on a monthly basis and went through these figures. I was breathing down their necks on this because I knew that it would be a big issue over winter. And I asked them consistently, what are you doing about this? Why are the rates so high? And I guess some of it was because they were more exposed. They were in the vehicles with people who had COVID and whatever. So that had an impact. I think some of it is because, you know, they were disillusioned because, you know, they were waiting for hours on end outside. So, you know, there was an issue there. So they had to do a lot of work, and it did come down, but I was asking them consistently what were they doing about it and how were they addressing this. So, you know, they did come down, but if you look at the numbers, they were on about 13.5% sickness rates in the February. So if we hadn't had the military in and the 100 new ambulance workers were only just coming online, it would have been really difficult.
I'm asked to ask you what, if any, consideration was given to filling the gap in the ambulance service by seeking to use the independent ambulance sector who were used nationwide in England to provide support to existing NHS ambulance services in Wales. Was that a possibility?
Well, we did use St John's ambulance, and so we did, but they can't do some of the emergency work that obviously the core ambulance group can do.
Thank you. Turning now, if I may, to NHS staff issues. Was there any means by which you were able, as Minister, to gain an understanding about the impact of the pandemic on the health, including the mental health and well-being of NHS staff and healthcare workers?
There was, and I'd just come from the role of being responsible for mental health, and there was a particular focus on supporting people in the NHS, and we had a whole programme of work. We put £1 million into supporting them through Health for Health Professionals support network that turned later into a programme called Canopy. So there was definitely an awareness that they needed support, and we put that support in place. So, you know, as I say, I visited the Frontline quite a lot, and I was very moved and touched by it. So recognising that people need support when they're under the kind of pressure they were was absolutely central to the way that we needed to deal with this pandemic.
In terms of risk assessments for NHS staff, workforce risk assessments, at paragraph 69 of your witness statement, you refer to the September 2021 report of the First Minister's Black and Minority Ethnic excuse me, COVID-19 Advisory Group, which set out the progress that had been made in developing the All Wales NHS Workforce Risk Assessment tool. Page 9 of that document showed that the Velindre Trust had the highest rate of risk assessing its staff, with 71% of its staff who had received a risk assessment. And 3 other trusts, boards rather, were assessed as having over 60% compliance. Did you think that that was an acceptable level of compliance? And do you think it should have been mandatory for all staff to be risk assessed by the local health board where they were employed?
I think the Black and Asian minority ethnic risk assessment tool was in place before I became a health minister, so I can't speak for what was going on then. But obviously, in an ideal world, you'd want everybody to have a risk assessment.
Do you think it would have been more effective to ensure or to require the local health boards to risk assess all their staff and to make it mandatory rather than an option, a tool that they could use if they wished to?
I don't know about that because I'm just thinking about all of the other pressures they were under. But I think we were particularly concerned with the Black, Asian, ethnic minority groups because there seemed to be a much higher incidence in terms of COVID and critical care and all of those issues. So we wanted to make sure that that support was in place, particularly for those frontline workers, and that they should definitely be considered in that risk assessment tool. But I guess it depends where in the system they are. So, you know, if you're in an office, the risk assessment is probably not as essential as if you're on the front line in an emergency department.
From your engagement with healthcare workers during the pandemic, do you think that the Welsh Government did enough to address inequalities for Black, Asian and minority ethnic healthcare workers?
I think the establishment of that group, as I say, that happened before my time. There was a real sensitivity to it. It was something we discussed very frequently in cabinet meetings. So I think, I'm not sure what more we could have done. What we've tried to do is to build on that, and now we have a very comprehensive anti-racism action plan that is following through as a result of that, because it wasn't just about people in the NHS workforce. There's a broader issue with society.
The inquiry has heard that although the local health boards in Wales did record deaths of healthcare workers from COVID-19 and kept statistics on that, the Welsh Government did not request any information on it and does not know how many healthcare workers lost their lives from COVID-19 across Wales. So Chris Whitty told the inquiry that information on deaths of healthcare workers is vital information for tracking the impact of a pandemic. In retrospect, do you think Welsh Government should have been gathering the data to monitor the number of deaths of healthcare workers during the pandemic?
Yeah, I think we should have, yes.
Finally, then, lessons learned and recommendations for a future pandemic. The inquiry's heard from the current Director General of the Health and Social Services Group, Judith Paget, that the Welsh Government or NHS Wales has not produced one single overarching report into the pandemic response of the Welsh healthcare system, as, for example, has been done within NHS England. Would it have been useful for you, do you think, as Health Minister, to have undertaken a lessons learned review across the healthcare system, or to pull together those pieces of work that had been done in order to reflect upon what lessons can be learned and taken forward for a future pandemic?
Well, we were doing a lot of lessons learnt as we were going on. That's what we were trying to do in between the various waves, so that it could make a difference as things were happening. I mean, we have had a lot of reports done in terms of how we managed COVID, what could have been done better. And you're right, in a sense, we haven't pulled them all together. I guess this inquiry would be very helpful in terms of pulling all those pieces together. And one of the things that I'm really keen to do is to have that comparison. You know, it's quite difficult to make an assessment sitting in one place. I think it's really useful to have the COVID inquiry to make those comparisons, what worked well in different places. And, you know, I think the inquiry is probably the best place to do that, because we've done all of the individual reports. Now we've got to get a better sense of, actually, they did that better in a different part of the United Kingdom. What can we learn from that? And I'm hoping that's what we'll get from here.
What do you think, given that you said the Welsh Government or NHS Wales has undertaken a number of lessons learned review, what are the key lessons that emerge from that, in your view? What is it? Is there anything that you think should be done differently next time?
I think there's lots that could be done differently. You need to prepare for a pandemic, and you need to prepare by making sure that you reduce inequalities before you go in. It's clear that the people who suffered most proportionately were people who were disadvantaged and who were vulnerable before we went in. So getting rid of inequalities is before you get in. You're never going to get rid of them entirely, but reducing them would make sense. And we've got a strategic plan that is very focused on that. And none of that is straightforward, because it's all kinds of things affect that, you know, education standards and what food you eat and all kinds of things. So, you know, going into it fit makes sense. You know, the state of the NHS estate is poor, so additional capital investment would be helpful. I think for us in Wales in particular, trying to get more separation between planned care and emergency care. It's challenging, it's difficult in a kind of population base that we have, but where we have since introduced that, not just in West Wales, but in that place where I found all those people not performing surgery. There's now a brand new hub that is being developed, so that we can keep things separate, and then we can advance the planned care and not see that slow up in the way we did. Our ability to change is always going to be restricted by finance, though, and that's the real challenge for us. And I think there were some positives. I think the digital transformation that happened as a result really quickly. Remote consultations, that's really worked for lots of people in relation to GP access, but also in secondary care, particularly in rural areas. You know, if you're a long way from a dermatologist or and you can do it all online, you know, that's a lot more convenient for some people. So I think the other thing is I think the NHS did remarkable work. I think the staff on the front line did remarkable work, and there's a lesson there as well to empower the frontline workers. I think give them responsibility. We gave them responsibility and we empowered them with a lot of money. It's very difficult to do that in times of peace, but what they did was just incredible under the circumstances, and they acted really, really quickly. And, you know, if we could bring some of that magic back now, it would be wonderful.
Thank you very much. I've no further questions for you, Baroness Morgan.
Miss Waddup, I think you're first up. Over that away.
Okay.
Good afternoon, Baroness Morgan. I represent 13 pregnancy, parent and baby organisations. You've given some very clear answers already about visiting restrictions in the maternity context, for which we're very grateful. I'd like to ask you, please, for your views about neonatal visiting restrictions. The inquiries heard from Chief Nursing Officer Jean White that her view in hindsight was that both parents together should always, i.e. from the beginning of the pandemic, have been allowed to be with their baby on the neonatal ward. Were you aware that Wales was the last of the 4 nations to direct hospitals to allow both parents to have unrestricted access to their babies on the neonatal ward, i.e. to treat them as one unit, as Mr. Gething put it this morning?
I think Jean White is right. I think we should have introduced that earlier. And I think it's a magical time for parents, and you need to allow them to be parents as soon as they can, irrespective of the circumstances. So although we may have been doing it for what we thought were the right reasons, there's a price that they've paid that they'll never get back.
Thank you. It's right, isn't it? I'm at paragraph 258 of your statement, that the neonatal charity Bliss had been flagging this issue, making these very points to Welsh Government representatives in summer and autumn 2021. They were advocating for immediate changes to the Welsh guidance. Do you recall that?
I do.
And it's also right, isn't it, this is at paragraph 263 of your statement, that it wasn't until May 2022, so almost a year later, that Welsh guidance, A, explicitly recognised the importance of parents being treated not as visitors, but as partners in care, and then B, moved away from the more discretionary trust-by-trust approach that had been in place previously, towards a more mandatory approach, essentially requiring hospitals to allow parents, both parents, to attend to their babies at the same time.
Yeah, we took too long. I took too long to make those changes. And if I had my time again, as I say, that's one of the things I definitely would have changed.
Thank you. Can you help us with the reasons for that delay? Was it, for example, due to a lack of priority being accorded to women's and maternity-related care?
I don't think it was because of that in particular. I think it was probably just because we were under an inordinate amount of pressure. I was still very much, a very new health minister trying to find my way through a very, very complex system. I was answering I was making 100 decisions every Sunday, on my day off. The intensity of this is something I just can't begin to describe. So, it wasn't deliberate.
Thank you very much. Those are my questions.
Thank you very much. Miss Jessica Jones. There you are, behind the pillar.
Baroness Morgan, I ask... Can I check that you can hear me? Thank you. Baroness Morgan, I ask questions on behalf of John's campaign, the Patients Association and Care Rights UK, all of whom are organisations representing people who draw on health and social care and their loved ones. My first question follows on from the theme that Ms Waddup was putting to you, the implementation of visitor guidance. Mm-hmm. And you said in your evidence that the national visiting guidance provided a baseline from which there was flexibility for local decisions to be made. What, if anything, did you or your department do to monitor how those restrictions were implemented, to ensure that local decisions to exclude or permit visitors were proportionate and adequately took into account the needs of individual patients?
Well, we were aware that there were differences happening around the country that were in keeping with the kind of waves of COVID and when they were happening. So people were, some of the health boards were letting us know when they were tightening up those visiting restrictions. So there was definitely monitoring going on in relation to that.
But even in times when there were local outbreaks necessitating greater restrictions, were you aware of how decisions were being made about specific patients who may, despite the particular local circumstances, have had personal needs that required a care supporter or visitor to continue to be provided access to them? And how was that kept track of?
There's no way as a minister, with the kind of pressures we were under, that I could have kept track on specific patients. I think that would have been getting very much into the operational weeds. And, I think you've heard earlier that my role was very much a strategic one, and the guidance was set out. The operational matters is always one for the NHS itself.
Thank you. Well, my next question is about consultation with patients. And here I don't mean individual patients, but representative organisations like those for whom I act today and others in this room and elsewhere. You've said that you would, in retrospect, have liked to have more views feed into the decisions that you made, and that there was difficulty in getting frontline views. But did you take any steps to try to obtain the views of patients and family organisations, to consult with them about patient experiences of the implementation of visitor guidance, for example, and the other issues that patients were experiencing in the delivery of healthcare during the pandemic?
So we have an organisation called SICE, which is the formal representative body that speaks up on behalf of patients in Wales. So obviously they were feeding in regularly to policy developments, to proposals. So there's a formal structure to make that happen.
And did you feel, therefore, that patient views were adequately represented in the decisions that you took?
I think the structure was definitely in place for that to happen. So what I can't say is whether the organisation actually truly reflected that when they were taking everything else into account.
Thank you very much. Those are all my questions.
Thank you, Mr Jones. Mr Weatherby, who's just there.
Thank you. Good afternoon, First Minister. I ask questions on behalf of the COVID Bereaved Families for Justice UK group, an organisation which includes many bereaved families from Wales. Just one topic, but an important one for those that I represent, and it's support for bereaved families. The NHS Wales National Nosocomial COVID-19 programme identified in its March 2023 interim learning report, I'll just give the reference for the record, INQ 000413883 at page 6. It identified that bereavement services were extremely important to those who'd lost loved ones. It identified that the provision of those services was inconsistent across Wales, and therefore identified as a key learning area that bereavement support service should be proactively made available in Wales to all families who have lost loved ones, and in particular where there's an associated patient safety incident, which would include COVID bereaved. Can you help us? What action was taken consequent to this report to ensure that the NHS in Wales was properly providing those bereavement services, and consistently so?
Thanks. Well, as I mentioned earlier, we did look into 18,600 or so cases in terms of who had people who'd got nosocomial infections, and that report, the national included a national framework for delivery of bereavement care, and that was launched in 2021.
Yeah.
And that produced then the National Bereavement Care Pathway. So that set out what should happen in the NHS throughout Wales. So that was the practical action as a result of the national framework.
Well, the national framework that you referenced was 2021 and is talked about in the report I've just referred to. But my question was that you had the framework. This report identified 2023 that effectively it was being applied inconsistently across Wales. So my question was, following this report, what was done to put that right?
I'm not clear. I'm not sure what was done to put that right.
Okay.
So I'll come back to you on that.
Thank you very much. That's helpful. I mean, the second question, probably the same answer, is that the second learning point was about proactively signposting bereavement services at the earliest opportunity. And my question again was the same, what was done about that? So I assume your answer is the same, so it would be helpful if you could possibly come back to the inquiry on that. And finally, about what assurance processes have been put in place on those two issues.
Well, I'm just trying to... So I've got the report in front of me, which actually sets out exactly what the key learning is, what the good practice is, and what should be done as a result. And all of that is set out in the end of programme learning report on National Nosocomial. This came out just after I'd stopped being Health Minister. So I can't tell you what's happened because I stopped being Health Minister when this report came out.
I won't take it any further, but the reason I put the interim report to you is because that was 2023.
Sure.
I won't take it any further. Thank you.
Thank you, Mr Weatherby. Mr Wagner, Mr Wagner's over there.
Good afternoon, Baroness Morgan. My name is Adam Wagner and I ask questions on behalf of the clinically vulnerable families. I want to ask you first, Baroness Morgan, about CO2 monitors. There's probably one around where you're sitting, they're sort of dotted around the inquiry room. Do you accept that CO2 monitors, just in broad terms, assess how well ventilation is working within a space and therefore indicate the relative risk of something like COVID-19 spreading in the environment?
I remember this being an issue that was raised by the RCN during the pandemic. They were concerned about this, and one of the things we did we did recognise that CO2 monitors had a role, but there were other things in relation to ventilation that needed to be considered, and that's why what we had was a NHS Wales Specialist Estates Service that looked more broadly at ventilation, not just at CO2 monitors.
Thank you. And I'll get there in the end, but can you just answer the question whether CO2 monitors in themselves assess how well ventilation is working in a room and therefore can be useful in assessing the risk that COVID-19 is spreading in the room?
I think there's recognition that there's a role for them, but I think they're not the only mechanism of making sure that conditions are what they should be in hospitals.
So it seems that you're accepting that they are a mechanism for assessing COVID-19. Do you therefore accept, given that they're a mechanism which can assess the risk of COVID-19, that they're also one of the few measures, not the only measure, but one of the few measures which could be implemented, which would allow clinically vulnerable people to monitor their relative safety when entering a healthcare space?
Well, I think it's got to be set against all of the other things that might be happening. So, as I say, that's a Specialist Estates Service. They were doing auditing, they were designing and making sure that they were alternatives. It didn't have to be all about CO2 monitoring, although they played a role also in giving advice on CO2 monitoring.
Sorry, just go back to the question I was asking. Do you accept that they are a mechanism whereby clinically vulnerable people can monitor their relative safety when entering healthcare spaces?
Yes.
Do you accept that CO2 monitors are relatively inexpensive to implement compared to redesigns of NHS estates or retrofitting of ventilation?
As I say, I think they're a mechanism. I think it's got to be set against all of the other things that are happening within that context. But yes, they are, relatively speaking, probably cheaper than some of the alternatives.
Do you also accept that CO2 monitors would assist healthcare staff in knowing which spaces require further ventilation or other measures, such as when opening windows, increasing air filtration, and the like?
I'm not an expert on these things. I'm not an expert on what system works better than the others. That's why we've got these specialist estate services to advise us on those things and what works best.
So on that, at paragraph 252 of your witness statement, you refer to a March 2022 letter sent by the Royal College of Nursing requesting that you take steps to invest in the NHS estate, provide CO2 monitors and infection prevention and control nurse consultants. Your response indicated that there were no plans to provide CO2 monitors due to differing air change conditions required on individual settings. And you gave similar answers in response to written questions in the Senate on the 11th of March 2022. And I just want to ask you about those responses. Do you recall this?
Yes, vaguely, yeah.
Yeah. Given that you accept the CO2 monitors can be a useful tool, that they have benefits to clinically vulnerable people, and they're relatively inexpensive, why wasn't a precautionary policy of providing those monitors adopted?
Well, there were huge pressures on us. We had to make difficult decisions in terms of precautionary approaches. We were generally taking a precautionary approach in Wales. This was not an issue that we didn't consider. But the key thing to remember is that the specialist estate services that I've mentioned were actually on the UK group that was looking at ventilation in healthcare settings, and they were looking at the monitoring of use of CO2 monitoring in healthcare. So they were doing that via a UK approach.
Looking back, do you think that was a bit of a missed opportunity?
You can't win, can you? Sometimes you say, why were you doing it differently? And now you're saying, you should have done it differently. So, we thought we were doing what we needed to do through getting the expert advice of NHS Wales Specialist Estate Services, and we were following their advice. They're the experts.
Portable air filtration systems. I think there is one next to you in the inquiry room. They're dotted around, sometimes referred to as HEPA filters. Professor Beggs, who is one of the inquiry experts, has given evidence that those kind of systems have the potential to supplement existing ventilation systems, so sort of hardwired ventilation systems. Do you agree that if there is a potential for a relatively cheap method of encouraging cleaner air, and therefore lessened risk of COVID-19 circulating within hospital settings, it should be properly investigated?
Yes, and I think that's what they were doing on that UK-wide group. But I do know about air filtration systems because I was given one for Christmas. It was the most disappointing Christmas present I've ever had.
Do you use it?
Not very often, but the reason it was bought is because I think my children, who were students at the time, were just about to come home, and it was just I think it was a little bit of a right. Let's see what we can do, but I've no idea how much it cost. As I said, it was a present, and I have no idea whether it made any difference.
Finally, I want to ask you about antivirals. In March 2022, the shielding programme came to an official end. And one of the matters that you relied on in making that decision was the availability of medical treatment for those at higher risk from COVID-19. This is in your statement at paragraph 277. Is that a fair representation of one of the factors that was involved?
It was definitely a tool in our armoury, yeah.
Yeah. In a letter sent out by the department on the 6th of April 2022, responding to concerns about ending the programme, you set out information about the availability of medical treatments and antivirals available to assist in combating COVID-19 and which could assist more vulnerable groups. A number of CVF's members, that's the group that I represent, report historic and ongoing difficulties in accessing antivirals within the required 5 to 7 days of infection, including difficulties of securing a referral, being positively triaged in time. Can you recall what, if any, processes you had in place to ensure prompt access to antivirals for those who were at the highest risk in Wales?
Yeah, I remember us having quite a sophisticated operation, so we had a very comprehensive database of who were on that clinically vulnerable risk group, and if they had COVID, it would trigger an alert, which means that they would get the antivirals that sent to them directly. So I thought it was quite a sophisticated operation.
Do you accept that if antivirals were in fact not practicably available for or offered to many people at higher risk from COVID-19 who became infected, they couldn't reasonably be considered as a justification for ending shielding?
Yes, which is why we had a very organised system to make sure that there was a very speedy response.
Thank you. Those are my questions.
Thank you, Mr. Radel. Ms. Haddett, she was at the back there.
Baroness Morgan, I ask questions on behalf of the long COVID groups. My lady, we're very grateful to Counsel to the Inquiry, who's in fact asked and raised all the questions that we were given permission to do. May I instead ask permission to raise one short question with Baroness Morgan regarding the evidence that she's just given this afternoon?
Certainly.
Thank you, my lady. Baroness Morgan, you gave evidence just now that just 3.5% of long COVID patients were referred to secondary care. Isn't this extremely low figure a red flag that long COVID patients are not receiving access to specialist clinical care?
I'm not an expert. That's why we had an assessment of the Adveriad programme, and they didn't flag up that they thought this was an issue.
Do you agree that it maybe perhaps highlights a misconception in Wales that long COVID is primarily about management of rehabilitation rather than a complex multi-organ disease which requires clinical management?
I rely on experts when it comes to how to clinically manage particular conditions, and that's particularly true in relation to what is a relatively new and still not entirely understood condition.
My lady, I'm grateful.
Thank you, Ms. Haddett. Ms. Shepherd, who's behind the pillar.
Prynawn da Prif Weinidog. I ask questions on behalf of COVID-19 Bereaved Families for Justice Cymru. We found a number of examples in this module where it appears that the Welsh Government did not subject itself to the same level of scrutiny about what went wrong during the pandemic as other nations of the UK. I've got 4 examples for you. Firstly, no national investigations into cluster outbreaks in hospitals were undertaken in Wales as they were in Northern Ireland. No pilot pulse survey akin to that which was undertaken by Professor Fong in England took place in Wales. The Welsh Government did not commission a look-back exercise or review to investigate into the issue of inappropriate DNA CPR exercises, as happened in England. And Welsh Government did not undertake an assessment of the effectiveness of its shielding programme, as Public Health Scotland and DHSC did. Do you agree, in light of those examples, there has been a failure by the Welsh Government to open itself up to scrutiny in relation to the performance of the healthcare system in Wales during the pandemic?
I think there's lots of things that we can learn as a result of the pandemic. This was an unprecedented situation, and we were all responding to the best of our abilities with the information that we had in front of us at the time. Are there lessons we can learn? Absolutely. I'm really hoping that this inquiry will help us to learn some of those lessons. No, we didn't do the national cluster exercise, but we did investigate every single individual that had a nosocomial infection in our hospital. I'm not sure if that happened across the United Kingdom. I'm not sure I think your second point on something about pulse, I don't know. Sorry, if you could
that was
repeat
the
that.
study where Professor Fong went into hospitals in England to look at what was happening on the ground, as opposed to just receiving the data.
Okay, well, look, you've heard that, I tried to do what I could as a minister within the parameters I could in the middle of a pandemic to get a better sense of what was happening on the ground. When it comes to DNA CPR, then we've had this follow-up to try and make sure that we initiate and we look at what more needs to be done in that space. And on shielding, I'd be very happy to see what the inquiry comes up with. The shielding in England stopped much earlier than ours did. So, it will be interesting to see what comes out of that. But again, we had to balance not just shielding, but also, as I mentioned earlier, the other issues that arise as a result of shielding, including social isolation and mental health issues.
I'm going to go on to my second topic, which is data collection. Major outbreaks in hospitals were recorded via, I think it's either the ICNet or the ICNet database. Mm-hmm. To what extent did you rely on the data from that database for policy making?
It fed into the general policy making approach.
We've learned from the statement of Professor Fumen Kaur from Public Health Wales that a surveillance quality assurance group was set up to feed back to the Welsh Government and health boards on any issues of data quality and completeness, and for health board medical directors to feed back in turn. What was your understanding of how that database was used by the surveillance quality assurance group to monitor and respond to outbreaks in hospitals?
I haven't got the detail on that information.
Are you aware of any deficiencies in the ICNet database?
I'm not aware of any issues, no.
I'm going to ask then that 327640 is brought up on the screen. I think it's at tab 52 within your bundle. For reference, these are questions that are posed by members of CBFJ Cymru in the one column, and the Welsh Government response column is from your time in office, so it was either by yourself or someone from your office. If we could look at page 3 of this document, in the second box down. What's said in answer to question 12 is, problems were identified with the outbreak module of the ICNet, which have been addressed. Are you aware of what the cause of those problems were?
I can't recall what the cause were, no.
In which case, I'll move on from this point. A concern of those who I represent is that the number of cluster outbreaks in Welsh hospitals, and was that a difficulty as a result of the data collection in Wales?
I'm not sure if it was a result of data collection. We were testing a lot of people. We were looking for it all of the time. So, we know our rates were very high, but we're actually looking for it, deliberately going out and making sure that we tested everybody. So that might have explained why our rates were higher.
Do you agree that there were gaps or deficiencies in the data recording?
In the middle of a pandemic, it wouldn't surprise me at all if that were the case. People were being stretched left, right and centre. People on the front line who were under incredible pressure, and I'm sure there were times when data wasn't recorded at all times accurately.
Did you take any steps to ensure that data on nosocomial infections could be properly collected and analysed in Wales?
Well, we had a specific group whose job was to give advice on nosocomial infections. So that data piece would have been a part of that group.
I'm going to move on then to the final topic, which is clean air. In March 2022, the Royal College of Nursing sent out a briefing that the spread of COVID-19 was higher in areas with poor ventilation. This in turn led to questions being asked of you about ventilation in the Senedd. Given that this had been a problem of which Welsh Government had been aware since the first wave, how was it that poor ventilation was still a problem in advance of the third wave in the winter of 2021-2022?
Well, we have older hospitals. You know, we've had years of capital restrictions, so we haven't been able to do the kind of we weren't able to do the kind of individual isolation that can be done in more modern hospitals.
Next topic then is HEPA filters. You spoke earlier about some of the things the Welsh Government can do to direct the health boards. Did you give any consideration to providing guidance or issuing a direction as to the use of HEPA filters in Welsh hospitals at a national level?
I can't remember giving any specific advice on that, no.
Diolch yn fawr. Those are my questions. Thank you, my lady.
Thank you very much, Ms Shepherd. Thank you very much, Baroness Morgan. Those are all the questions that we have for you. May I say this, that you are one of those rare beings, which is a witness who answers the questions in a focused manner and a relatively short manner and at a measured pace. And I can tell you that not all of us can claim such a thing. Anyway, thank you very much for your help.
Diolch yn fawr, thank you.
Very well, 10 o'clock tomorrow.